Everybody, I'm Raj Dave from Camp Hill, Pennsylvania, your host for C3 Live. Today's topic is precision PCI in 2024. It's an extremely important topic. As you all know, ambulatory PCI is now a big wave in the United States, and CMS has approved FFR, IVUS, as well as OCT. All three procedures in ambulatory surgery centers really a revolution in the thinking of the agency in the United States, and precision PCI has become extremely important moving forward. So our first speaker is Dr. Jung Joon Cha. He's an assistant professor at Cardiovascular Center in Korea University, Anam Hospital. He's been to C3 course before. He's not new to the C3 program. And he's going to talk about IVUS in 2024, how I utilize IVUS to guide PCI in my daily practice. Welcome, Dr. Cha.
Thank you. It's a great pleasure to hear in online and present this wonderful title, How I Utilize IVUS to Guided PCI in My Daily Practice. My name is Jung Joon Cha. I'm from Korea in Korea University Anam Hospital. So these are contents. We're gonna find some IVUS guided PCI, and I show you some cases for using IVUS. And also I'm talking about the near IVUS guided PCI. So there are numerous key clinical data of IVUS guided PCI from 2050, the CTO IVUS, IVUS XPL, and Ultimate trial. All trial is conducted from Korea and China, and there is some significant improvement in MACE or TLF and TVF in IVUS group rather than compared to the angio groups. And also extended merger data also shown the similar result in improvement of TLF in IVUS group compared to the angio group. So the randomized trial clearly demonstrates the benefit of IVUS guidance for the clinical outcomes, but not hard endpoints like deaths or MI. However, in cohorts or registry data regarding IVUS versus angiographic guided PCI demonstrate the benefit of IVUS guided for the hard endpoint, even deaths or MI. Last year, as you already know, the Renovate Complex PCI was published in NEJM. These studies compared to the image-guided PCI and the angio-guided complex PCI. So in IVUS, in image-guided group, the IVUS using the 75% of the all image-guided PCI groups, and there is a significant reduction regarding TLF compared to the angiographic guided PCI. So recent guideline recommended the use of intravascular imaging. In patients undergoing coronary stent implantation, IVUS can be useful for procedure guidance, particularly in case of left main or complex coronary artery stenting to reduce ischemic event. So class 2A and level of evidence B. Also, the inpatient with intermediate stenosis of the left main artery, intravascular ultrasound is reasonable to help define the region severity. So when we using intracoronary imaging during PCI, we have several advantages regarding pre-interventional assessment and region preparation and stent deployment and assessment of post-procedure endpoints and complications. In aspect of pre-interventional assessment, we assess plaque composition, region characteristics, and find mechanism of stent failure. And we try to find landing zone and choosing stent and region preparation strategy. And also region preparation and stent deployment confirm landing zone, prepare region, and determine success of preparation strategy and optimize stent expansion. And after the post procedures, we checking the stent under expansion and malposition deformation, and edge dissection can be noted by using IVUS, intravascular imaging. And Recently, the JAG intervention publishes these prognostic differences, impact of operator experience, and IVUS guidance on long-term clinical outcome after complex PCI. This graph shows the 10-year risk of cardiac death or target vessel MI. So as you can see, there is less experienced operator using the much benefit when they using IVUS compared to the angiography alone. But the experienced operator also have the benefit when they using IVUS compared to the angiographic guidance regarding the cardiac death or target vessel MI. So then how I utilize IVUS to guide PCI in my daily practice. So I'm working in the Korea University of Medicine. The Korea University has 3 hospitals. This one, and this one, and this one. So this is the Anam University Hospital, which I work for. So Korea University Anam Hospital have 7 operators and 3 cath lab. We annually about 900 cases of intracoronary imaging were conducted. In most cases, we are using IVUS and some cases for the OCT. So now I want to talking about the several cases about the complex PCI, like severe calcification region, chronic total occlusion, or bifurcation regions. So these are first case, 63 males years old, they have a severe coronary calcification in CT, and there are significant stenosis of proximal RCA and distal RCA. But when we are using the NC volume 2.75, but not fully expanded, so vigorous management occurred proximal dissection. So we handle this point for successfully stenting, and we decide to rotablator 1.5 millibur to the correction for distal lesion. But after the rotablator, still 2.5 millimeter burden does not fully expand it. As you can see, there are significant calcium, and circulating calcium in here does not break even when using 1.5 millimeter burr rotor. So we increased burr 1.75 millimeter burr. After that, we finally achieved the full expansion of the balloon. And after that, with DS implantation, this is a final angiography. So when we using IVUS in severe calcification lesion, so baseline IVUS is show the circulating calcium after 1.75 rotablator, there is some crack, and after the balloon, as you can see, there's a post-balloon expansion was clearly showed that there is a crack and expansion, and stand-up position also checking by IVUS is better than the angiography. So this is another cases for the RCA CTO, the 67 male-year-old who have the stable coronary artery disease, but there is suspicious recanalization of the after the CTO. So maybe there is some true lumen about the among the several channels. So I try to using workhorse wire with run through to the finding the true lumen, but there is some resistance after the advanced distal lesion. For angio show, there is some lumen, but in other projection, there's a subintimal spaces. The wire is gonna in the subintimal spaces. So I'm changing the plan to the CTO wiring. So when we several attempt using the parallel wire technique, the Gaia next to one, going down the true lumen like this. So we're checking the true lumen after the 2.0 millimeter balloon. We're checking the IVUS first. As you can see, there are diffuse atheroscleral region and also subintimal hematoma also shown, and suspicious of recanalization portion in here. but the whole wire penetrating a true lumen, and this is a proximal references. So after DS implantations, we're gonna checking. The angiography looks good. So after the NC 3.5 millimeter balloon, we're checking the IVUS again. There's a stent good opposition of the distal edge or proximal edge, and well expansion of the whole stent length. So when we pull back the IVUS, we're checking the diminish of the intramural hematoma, or the opposition and expansion should be checked. So this is another case for the left main bifurcation, Medina class 110. So as you can see, there are no significant stenosis of the circumflex ostium, but the left main distal and LAD proximal significant lesions. So I will first show the proximal lesion of 90% plaque, and there is significant stenosis of the middle LAD. There's a significant calcium on the middle LAD. So because there is no significant stenosis of circumflex os, so I decide to cross over the left main to LAD. So 3.25 millimeter DES was implanted for left main to medial LAD. When we checking, before checking the IVUS, we just adjuvant NC balloon 3.5 millimeter to the stent optimization. And expansion was checking by IVUS. This is a pre-procedure 90%, but now fully stent expansion as well opposition of the distal edge. And you can see there's a proximal edge is a good opposition, but this is a circumflex os. But when we checking the caudal view, there is an increased haziness of circumflex ostium. So we decide to FKI. So we decided 3.5 millimeter and 2.0 millimeter balloon to kissing balloon. And after that, angiography looks good. And we're checking the IVUS in both sides, circumflex to left main. As you can see, there is a good patency for the circumflex os on LA to left main. Compared to the previous IVUS images, circumflex os is sufficiently achieved. So now this is a final case. The CTO plus left main bifurcation. So the left, as you can see, there's a proximal LAD of a CTO lesion, and also circumflex ostium has a significant stenosis. So we're firstly trying to overcome the CTO. So when we're using STA but not penetrate, so we're using Gaia next to distal area. After 2.5 millimeter balloon, we checked IVUS for the left main to LAD. There is a negative remodeling, and we assume there is a distal landing point in here. And all wire is secure in the true lumen, and this is our CTO lesion. And they are coming from the circumflex ostium. And there's a significant stenosis of left main, and maybe this is the proximal references. So first, we trying to 2.75 millimeter DES was implanted to proximal LAD to middle LAD. So immediate stenting result looks good. And we decide to stent. So after the 2.5 millimeter balloon circumflex ostium, there's significant stenosis in circumflex ostium to left main. So decide to mini crush technique for this true bifurcation lesion. So 3.5 millimeter DES was implanted first to the side branch and adjust left main proximal LAD stent position using angiography, and DS 3.5 millimeter DS was implanted. And after kissing balloon, the angiography looks good. So we're checking another IVUS. First, we're checking the left main to circumflex ostium. As you can see, this is a circumflex os from circumflex os to left main, and this IVUS show the distal LAD. Medial LAD portion is quite 2.5 to 2.75, and proximal region is good expansion, and here comes a circumflex ostium, but still under expansion for the left main. So proximal optimization technique was done by 4.5 millimeter balloon. After that, the angiographic looks better, and also I will show the sufficient expansion of the left main. So these are final results. So summary for IVUS guided PCI. The IVUS guided PCI has shown benefit not only in patients with complex lesion, but in all comers. The benefit of IVUS guided PCI are more pronounced in early career operators, but the benefit persists in experienced operators also. And stent optimization by IVUS is not difficult and simply applicable in all comers. The next thing is I want to show and I introduce a near IVUS guided PCI. Then what is near IVUS? The near infrared spectroscopy is not visible to the human eyes and with low energy, so there is no harm the patient. And this near infrared spectrum provides the lipid profiles as using multiple components. So as you know, the plaque vulnerability is one of the important things is acute coronary syndromes. So now the vulnerable plaque has a various criteria. For the major criteria, thin cap with large repeated core is one of the major criteria of the vulnerable plaque. So basically, near IVUS system is an IVUS system and also has NIRS. So NIRS provide additional information on plaque characteristics regarding lipid core detections. So NIRS have the specific proven level claim for the lipid core detections. So these are demonstration of the near IVUS. This whole system is similar to other IVUS systems. So when we're flushing the catheter and connecting the catheter to console, so the pullback sequence is the same in other IVUS systems, but there is one thing difference. There is a chemogram in here. Then what is chemogram? So near IVUS has two sensors, an IVUS sensor and near sensor in one catheter. During the IVUS analyzing the whole system, the near also rounding the whole vessels simultaneously. Then the nears checking whether there is some lipid plaque or the fibrous plaque in here. So these are chemogram. The chemogram show the yellow part is a high lipid plaque in there, and red dot is not quite much of the lipid plaque. So the same stenosis of the proximal lesion and distal lesion, but the yellow plaque is means for the lipid-rich plaque, and red is a fibroproof plaques. So here is the case. So there is a effort angina in 73 females come of our hospital, and there's a significant stenosis in the circumflex distal area. So we checking the first circumflex regions. There's a significant stenosis over the 70% of area stenosis, and quite high for the LCBI max. So we simply stenting for the distal lesion, and the stent is good opposition, and the IVUS show there is a good opposition and the full expansions. But which is LADs, it is some intermediate stenosis, but we checking the IVUS with near. There's an area of stenosis only 60%, and the lipid core burden is numerically 400, is quite high. But there is intermediate stenosis, we just differ. But unfortunately, and after 3 months, patient come emergency room and presenting for non-STEMI. Her LDL level is 57, but as you can see, there are significant progress in the middle LAD lesion. So this is a before, and 3 months after, there's a significant progression of the middle LAD. So we're checking near IVUS again. As you can see, there's a stenosis is in progress to 73%, and also the LCBI index is over the 600. Compared to 3 months ago, the LCBI max is increased. So we're choosing the stent for the middle LAD lesion. But after that, the stent fully expansion and no edge dissections. So this result is already reported in prospective 2. So they said a non-complete lesion with the high LCBI max is a high risk for the subsequent cardiovascular event. So we have to know the high lipid burden plaque to prevent the subsequent cardiovascular event. So Pengman AMI trying to reduce using the high intensity statin therapy or the PCSK9 using PCSK9 inhibitor. So they said they in super intensive lipid lowering therapy made some advantages for volume reduction and even the reduction of the max LCBI 4 millimeters. And also the NIR can be using for the Carplet lesion or for the descending stent lesion. As you can see, there's a proximal lesion to the middle LA stenosis. So the findings are near IVUS. So the yellow dot means a high lipid burden in here. So we're choosing whether the stent edge may be positioned in this lesion. So there's a quite huge plaque in here. And there is no lipid plaque and also lipid plaque in here. So we can choose the stent length by using this cameragram and also IVUS information. So this is your diagonal branch. So if you want to stenting, you can choose this length or this length. In these cases, I just using cover the short segment and also follow-up nearest IVUS show that there's decrease of LCBI and there is no significant dissection or flow limitations. So these are final results. The stent opposition is good and fully expanded, and also we avoided this yellow dot, which makes rupture or other things. And there is one more thing we can using your IVUS to prediction of the no reflow phenomenon. The similar stenosis of area stenosis, but after the balloon, this one is occurred is no reflow phenomenon, that this is not. Why happened these differences? This might be the LCBI max is higher in this lesion and this is lower. So we already published the article. There is some association. So how high LCBI max in association with high max LCBI with the no reflow phenomenons. So these are my final slide. NIRS provide additional information on lesion upon IVUS guided PCI for the non-culpable lesion and culpable lesion. So we should using the intravascular imaging, especially IVUS, to the improvement of the clinical outcome for the who underwent PCI. Thank you for your attention.
That's great, Dr. Cha. It was an outstanding presentation. One question that I have is that how frequently do you do NIRS when you do IVUS? Because it's, of course, an additional time, for interpretation. And sometimes, people, physicians have comments that, that there's no strong scientific data supporting NIRS imagery to a connection to an outcome of the PCI procedure. But clearly you are showing that it's immensely useful, and now we have an integrated catheter from NIPRO in US where we can have NIRS and IVUS both in the same catheter, which makes a lot of sense. I've had the opportunity to use some of those catheters, and the images are very nice. So tell us, how frequently do you do NIRS?
We have both both IVUS system in Boston and your IVUS, so we can evenly using the both way. But technically, we don't need additional time for the near IVUS analysis because it's basically IVUS system. So chemogram data is achieved simultaneously with IVUS system. So we just exactly in that time there is high LCBI max and low LCBI portion. So I think there is no need to additional analysis for near IVUS system in real clinical practice.
Okay, great. Any other comments from any other moderators? Okay. Well, thank you so much. It was outstanding once again, and great cases. Very, very useful technology. And we really appreciate you taking the time very late in the evening in Korea to be a part of this session. Thank you so much. Oh, actually, in fact, there is one question from the audience. Near in obstructive lesion agree that PCI is indicated. What is the indication of NIRS in moderate mild lesion but PCI is performed? Any evidence for this approach? Okay, then maybe I'll reword that. That if you see moderate to mild lesion on NIRS, should you be doing PCI?
I'm not sure, but the prospective 2 may suggest for that lesion. In that plaque burden over the 65% and LCBI max is over the 400, it has a high risk for the subsequent cardiovascular event. So they conducted a prospect observe to using high risk of vulnerable plaque to prevent method to using the BVS, but the result is not significant. So in this time, we using the high intensity statin therapy to stabilizing the plaque first, and PCI is will going after the significant stenosis.
Okay, thank you so much. So thanks so much again, and it's now my honor and privilege to have my friend Carlos Collet from Aalst, Belgium. He's Associate Director of Cardiovascular Division at Olev Hospital in Aalst. He has done a lot of work on physiological testing, coronary CT, guided PCI. He's a frequent contributor to C3 meeting as well as C3 live shows. And it's a great pleasure to have him today to talk about physiological testing in 2024, that how to utilize physiological testing.
Raj, thank you very much for that introduction, and I hope you can hear me well and you can see my slides. and again, it's a
We can
privilege
see
to be
slides. We can hear you well.
excellent. It's a privilege to be back here. And let me just make a start here. And basically, we are going to go into the two main coronary compartments, which has been divided, by kind of simplify the approach to the coronary circulation. But we all know that this is just one system, and basically all the flow that goes through the epicardial vessel depends on the microvascular dilatation. So we're going to cover all this continuum of circulation and how we can assess these both at the epicardial level and at the microvascular level with the different index that we have available. And I'm going to show the latest data in this regard. So if we start with the epicardial compartment and we go back to the beginning of our field, this is nothing new. If you look at the first paper of Andreas Grunzig, or the paper describing angioplasty in 1979, and you go to the figures of this manuscript, you will immediately see this type of pressure trend. And basically, what you have on the screen is the first intracoronary pressure pullback performed again in 79. And what Andreas Grunzig was using this pullback of pressure for was to identify first that the lesion that he was about to treat with angioplasty was indeed a focal lesion from the functional point of view, and that is clearly depicted in this beautiful tracing with this focal pressure jump here on the right side of the trace. In addition to that, Grunzig also measured what we call today post-PCI physiology. In other words, he dilated the lesion and then he measured the pressure again to be sure that the revascularization that he had done was effective. And of course, he correlated that at that time with percent diameter stenosis. And you see how clearly the translesional pressure gradient before the PCI as the black dot was reduced after the angioplasty shown by the white dot. Now, let's fast forward 40 years from that time to today. And when you look at the data that we have available in stable patients coming to the cath lab for symptomatic coronary artery disease, this is the reality. Out of 4 patients that we treat with a successful PCI, 1 of them remains symptomatic. And in that particular patient is the one that if you measure, let's say, fractional flow reserve after the PCI, these patients will have low fractional flow reserve, and those patients will have a higher risk of both dying or having an MI in the subsequent follow-up. To understand what is behind all these differential outcomes of patients undergoing PCI, it's necessary to understand physiology in a different way from what has been used to be physiology in the trials that have been performed in the last 5 to 10 years. And I'm referring to the fact that if you look at FAME 1, FAME 2, FAME 3, and all the other studies in resonance physiology, all of these studies have been based on one single value, the cutoff of 0.8, 0.89, depending on the index that we're using. But actually, we need to use kind of a second level of physiology. I call this a second dimension of physiology, which is a pullback maneuver, and I will explain you why this is so important. Let's use these models, the coronary arteries, to understand what happens when we perform PCI in focal versus diffuse coronary artery disease. And we're going to start with the focal coronary artery disease model because it's the easiest one to do. Basically, when we put a pressure wire in a coronary with a focal coronary artery disease and we measure the FFR distally, it will be low, in this case 7. But when we start pulling back the wire, and this is a manual pull, but it takes 20, 30 seconds, we see that when the pressure, the sensor pressure crosses the lesion, we'll see the same step in the curve that Andreas Grunzig saw in 79 in the case that I showed you before. Now, you can imagine if we identify this high translational pressure gradient and we treat this with PCI, look at this right side of the slide, you will see that there is complete restoration of the epicardial flow. And if you measure post-PCI fractional flow reserve, it will be very high, in this case, 0.95. Now, what happened in diffuse coronary artery disease is completely different. And I will go in the same approach. We're going to put a pressure wire distal in that LAD. We're going to measure fractional flow reserve, and it can be exactly the same as it was in the case of focal disease. But the difference is not the distal FFR, but the morphology of the pullback. You will see that we start pulling back the pressure wire, but at variance with the first case, we don't see a clear step up in the curve. The problem is that we basically use angiography, or you can even use any other sort of intravascular image modality, and you will always find a place in the coronary artery that looks more tight or tighter than the other place, than the other segment of the coronary. And we're tempted to implant a stent. These stents are usually longer, and we place it in that particular segment of the coronary artery. Now, look at the right side of the slide and see what happens to the morphology of that pullback curve after PCI. There is almost no increase in flow. And if you measure fractional flow reserve after PCI, it remains low, 0.8. Therefore, based on physiology, we can identify two different patterns of disease that respond differently to PCI. In other words, in patients with focal coronary artery disease, we have an increase in blood flow after PCI, and in patients with diffuse coronary artery disease, diffuse coronary artery disease identified by physiology, we see little or no improvement of blood flow after PCI. Now, this leads us to this concept that physiology actually helps us deciding what to do in two ways. One, it helps us understand whether the disease that we're treating is significant or not. In other words, does this lesion need to be treated? And in this case, both cases have an FFR of 0.71. But the second part of physiology, which is the pullback curve, helps us understand how this lesion can be treated. And of course, we have in this slide two different diseases with the same fractional flow reserve. On the left side, focal disease, very good for PCI. On the right side, diffuse disease, not good for PCI. Now, the problem that we had so far is that we didn't have the correct tools to identify diffuse disease. And that is the reason why physiology is so important in this regard. In other words, we cannot identify diffuse disease with angiography. Basically, the method that we have before relied on purely visual assessment, and you know that this leads or is associated with low reproducibility. And again, we have demonstrated that when you assess the pattern of coronary artery disease anatomically, it's completely different to the one that you can identify using physiology. And physiology leads to a reclassification of the cases of 1 every 3 cases. Now, the second problem that we face when we use physiology in this manner is that when you look at the pullback curve, it remains a visual assessment. And of course, when you have extreme cases of diffuse disease or focal disease, there is not a problem. But when you start looking at cases like this, or like this, or like this, you are immediately faced with an issue that some of the people looking at these pullbacks, we are going to say this is focal or this is diffuse, and there is actually a mix of the pullback pattern. For this reason, and again, this again, the problem of visual interpretation that again leads to, it's associated with high variability. And for this very reason is why we developed this concept of PPG. PPG is just a pullback pressure gradient, and it's a number that is extracted from the fractional flow reserve pullback curve or from a non-hyperemic pullback curve, namely IFR or FR, it doesn't matter. When we actually quantify the pattern of coronary artery disease, the PPG is a metric that goes from 0, there is diffuse disease, to 1, there is focal disease. And again, it's a continuous metric showing the complete spectrum of coronary artery disease. And this is meant to complement the classical assessment of either FFR or IFR, which identifies ischemia. PPG actually informs you about the likelihood of success of PCI. Now, what do we know about PPG? So what we know about PPG is, first, this plot represents the change in flow in the vertical axis, in other words, the change in fractional flow reserve, plotted versus the horizontal axis, which is the PPG. In the PPG, if you look at the values close to the left, these are diffuse disease, and the values close to the right, this is focal disease. And you immediately see that in patients or vessels with focal coronary artery disease, the change in fractional flow reserve is higher or greater than in those with diffuse disease. But sometimes after PCI, there is really no increase in flow. And if you look at the coefficient of determination in this particular plot, you will understand that half of the improvement in blood flow of PCI depends from the disease on the patient and not on the PCI technique. And this is completely a new concept. And of course, we already knew, starting by Grunziker with the new data looking at post-PCI fractional flow reserve, that if you have diffuse disease and you end up with low post-PCI fractional flow reserve, you will have a higher rate of cardiac death and myocardial infarction. It's not only about our endpoint, it's also about angina. This is a paper for our group published a couple of years ago, showing that patients with diffuse disease have residual angina rate of more than half, to 52%, that is significantly lower to the residual angina rate in patients with focal disease. And recently we published this, we presented this at TCT, showing that also in hospital outcomes, so periprocedural myocardial infarction is significantly higher in patients that are treated with PCI with a baseline diffuse coronary artery disease pattern based on the PPG. So we are using physiology not only to understand whether the disease is significant or not, but also to understand what would be the response to PCI. And we have now understood that post-PCI fractional flow reserve actually depends on a number of factors, which the most predominant one is the presence of baseline diffuse disease. And again, when the post-PCI fractional flow reserve is low, this is associated with increased MACE, and when the change in FFR with PCI is high, this associates with relief in angina. One of the very interesting things that we have realized recently is the fact that there is a connection between physiology and plaque composition. And what you see in this slide is the fact that when you analyze OCT vulnerable plaque features, namely lipid-rich plaque or Finca fibroteroma, and you stratify the presence of those by the pattern, the physiological pattern of coronary artery disease, we have started to understand that the presence of lipidic and higher risk plaque based on the composition are predominantly observed in patients with focal high translational pressure grade. So that was the update that I want to tell you about the epicardial part of the presentation. Now we're going to go to the micro circulatory part of the talk. And there is a lot of things happening in this space, and I have selected the most important things that have happened. And again, we have a new index for the coronary microcirculation. This is called microvascular resistant reserve, or MRR, that comes to complement all the other metrics like IMR, HMR, and of course we have the good and old CFR, which I'm going to refer in a minute. What is important to understand is, what is CFR? Well, this is very simple. It's basically the amount of times that the flow can increase in response to microvascular dilation. And if the microcirculation can dilate more than 2.5 times, we call this microcirculation normal. So this is the starting point. Now, there are two reasons why the CFR can be low. This is a formula, so it's basically calculated dividing the maximum flow that you can achieve, divided by the flow that was present in that particular vessel in resting conditions. And this ratio can, of course, be low because your maximum hyperemic flow is lower than expected. And that is a condition that we can identify by two main features. One, of course, the CFR is low. And second, the microvascular resistance is going to be high. And this is identified by an IMR greater than 25. The opposite side of this problem, or the other alternative to have a low CFR, will be the case that the resting flow is elevated. In this particular scenario, we have reduction in CFR with normal IMR. We call this functional CMD, and it's again another a scenario that you might face if you do microvascular testing. In summary, what we know is that the normal microcirculation, again, you have high resting tone at rest, and when you induce hyperemia, you have low hyperemic tone, low tone in hyperemic conditions. And then we have kind of dissected this coronary microvascular dysfunction into two. The first one that we call structural CMD, where the problem is that we cannot dilate the vessel sufficiently in hyperemic conditions, and that is the reason why CFR is low. We call that structural CMD. And then we have the opposite scenario where the CFR is low, not due to problems during the hyperemic phase, but due to problems during resting conditions where the flow is too high. Now, independent of the mechanisms that is leading to a low CFR, we have sufficient and a huge body of evidence supporting the association between an abnormal CFR and, in this case, mortality. And you see here the amount of patients in this meta-analysis showing almost a fourfold increase in death in patients that have low CFR. Now, until this moment, or until this year, basically, this remains something that was not actionable. In other words, you measure CFR, and then what? Well, that has been addressed by the group of Divata Pereira in London, and they have published this trial a couple of months ago in Circulation, and I will explain you the main findings. And what they have done is that they have performed microvascular testing in a number of patients without epicardial disease, and all of them have been treated with medication. They basically test two medications. One was ranolazine and the other one was amlodipine, and they gave that to all the patients. Now look what happened. Only the patient with coronary microvascular dysfunctions that are on the left side of the slide reported an improvement in exercise time and angina. I'm going to show that in the next slide with the beginning of the medications. And those patients are presented to the cath lab without epicardial disease and normal CFR that were treated anyway because of the design of the study reported no benefit of the medication. And this, of course, makes this investigation relevant in the sense that if you identify the presence of CMD with CFR and you treat those patients, there is evidence that they will improve, at least in the exercise capacity. And if you treat patients that you think that they have coronary microvascular dysfunction, but you don't test them, and they have a normal CFR, that medication basically will do nothing, and then you will see again no improvement in exercise capacity. And this was again shown in the improvement in the Seattle Angina Questionnaire, where patients with treated with CMD were the ones reporting increase or better improvement in the quality of life after the medication. Now, what do we know about long-term prognosis? Well, this is a very important slide because it shows, one, that the patients with CMD, it doesn't matter where they have functional or structural alterations in the microcirculation, they both have higher incidence of MACE and TVF, but it also shows that if you have a patient with normal CFR and even having high microvascular resistance, this is the second bar in both plots, these patients have good prognosis. How does this translate into practice? Well, these are the patients that have low CFR with normal IMR. You should not be worried about these patients because they actually have good prognosis. Again, we have several methods to assess the microcirculation. I don't have the time to go through all of them. Of course, we have bolus hemodilution, which is available in many cath labs around the world. We have a new system called continuous hemodilution, which is also FDA approved, and the experience being started in the United States recently. And we have Doppler that is not available anymore in the market. So I'm going to refer to the two thermodilution approaches. On the left side, bolus thermodilution, that is very easy, very fast, but is operator dependent. And on the right side, you have continuous hemodilution that requires a dedicated catheter for infusion. It is more precise. It takes a little more time. You have to pay the extra microcatheter, but it provides us for the first time with measurements of absolute coronary flow in milliliters per minute and microvascular resistance in Woods units in the coronary arteries. So it's really a huge step forward in the diagnostic method that we have to assess the coronary microcirculation. Now, I'm going to focus on the method called bolus hemodilution. I would explain how it works. Basically, we're going to use the same pressure wire, and it's actually the same pressure wire that we use for the FFR. And it's very simple. We basically inject a bolus of saline, and this wire senses the temperature at two places, at the proximal part very close to the guiding, and in the distal part of the vessel. And again, because this is based on time, and we know the time that it takes from that bolus of water to come from the first sensor to the second sensor, we calculate that as a mean transit time, and that has been shown to be a surrogate of flow. And this is, again, very practical and very simple. So basically, this is the type of results that you get when you assess the coronary microcirculation. You get, of course, the whole epicardial assessment, FFR, and PVPA. And again, what you see here is the flow in this time, some sort of a surrogate of velocity, this mean transit time, the one in rest, 126, the one in hyperemia, and you see here that the hyperemic time increased 2.2 times, and that is, of course, the result of the CFR. And then you see here automatically the calculation of the IMR. So this is a representative example of a patient with coronary microvascular dysfunction from the structural endotype. Now, what do we know about IMR? I'll go very quickly through the clinical validation of IMR, because this has been validated in acute patients after STEMI. And you see here that if you end your PCI, your primary PCI, and you have a high IMR, in this case more than 40, these patients have worse prognosis. And again, this is survival after primary PCI. The second clinical scenario where IMR has been validated is in patients undergoing elective PCI. And you see here immediately that patients that end up at stable PCI with high IMR, probably reflecting some degree of distal embolization and iatrogenic increase of resistance to PCI, have worse prognosis, both in terms of death and the occurrence of spontaneous myocardial infarction. However, it's very important to mention and highlight that in the field of coronary microvascular dysfunction in patients with non-obstructive coronary artery disease, there is the value of testing the microcirculation to identify patients with low CFR, and this was basically shown by the Cormica trial a couple of years ago by the team of Collet from Glasgow, showing that when you identify those patients and you treat those patients, these were associated with improvement in angina. But we also need to recognize that IMR alone has not been associated with adverse clinical events, except in the group of patients after heart transplantation. So, in other words, the most important metric to assess the coronary circulation in patients with non-obstructive coronary artery disease is CFR. I'm not going to go to the new index called MRR. This has been just described by our group a couple of years ago in JAC, where it's actually an improvement of the IMR, now incorporating the amount of times that resistance decreases. And this is, again, a formula that is able to adjust for the presence of epicardial disease. So it's really a step forward, and we're currently validating MRR in a trial called Aerocraft. We have already half the patients included, and the results of this study will be ready in a couple of years. Now, to answer the question, I apologize, I have a typo. Coronary physiology should be in 2024. So I think this is the way that we use physiology, at least in our lab. We use physiology to understand what is the problem, what type of problem is present, what do we need to do, and how we can confirm the optimization of the therapy. And basically, it depends on the amount of obstructive disease that you have, the ways that you can use physiology. If you have a patient presented with non-obstructive coronary artery disease, we're going to go to what we call the microvascular pathway. If you have patients with intermediate stenosis from 30 to 90%, we're going to go to the epicardial pathway. And we have to recognize that there is no room for physiology. If you have a clear-cut 90% stenosis in a symptomatic patient, this patient should be treated immediately. I'll show you the full algorithm. And it's basically, if you go to the top of this algorithm, patients with non-obstructive disease should be interrogated with a pressure wire to understand first how is the CFR, and again, make a further stratification into functional or structural CMD, and then, of course, treat accordingly. And if you go in the mid part of the algorithm, what we call the epicardial pathway, again, important, we should start by measuring what we call the single distal point of FFR, complete the assessment with a pullback maneuver, and after having both the distal FFR and the pullback, decide on what to do. Of course, patients with significant and focal disease should be treated with revascularization guided by imaging, and those with significant but diffuse disease, we believe that today the best approach to treat these patients is with medical therapy, reserving revascularization for patients with refractory angina. So, in summary, I think that today, in presence of symptoms, I think physiology allows to understand many aspects of the disease of the patient, both including the epicardial and the microvascular part. Of course, the epicardial part is assessed by fractional flow reserve or any NHPR, and the microcirculation with CFR. In presence of epicardial disease, it is mandatory to use a pullback to understand the disease and what would be the response of that vessel to PCI. And again, I didn't go to the use of post-PCI physiology, but if you have employed pre-PCI physiology and you want to assess how the vessel has improved, you can, of course, do as Grunstick did in 79, confirm that the revascularization has been successful. So today, coronary physiology has evolved, and is not anymore a diagnostic method to know if the lesion is significant or not. That is completely past. We're using physiology to understand what will be the prediction in terms of symptoms improvement and quality of life, and again, as a correlate to the presence of vulnerable plaque. PPG is a metric that will become available pretty soon, and it's available and is able to quantify how focal or diffuse the coronary artery disease is, and this, of course, as you can understand, will further refine the indication for PCI. And finally, the presence of coronary microvascular dysfunction, it's important to understand what are the endotypes, but most important is to identify the patients with low CFR and treat them accordingly, because we now have evidence that treatment of those patients improve quality of life. And with that, I would like to thank you for your attention and of course, open to any questions.
Carlos, thank you very much. We have several questions from the audience. So the first one is in US, acetylcholine is not available in an injectable form. Is there any other way of doing testing for spasm besides using acetylcholine because of the problem of the formulation?
Yeah, right. I want to tell you something that few people like to talk about. In Europe, we also don't have acetylcholine to inject in the coronaries. Okay, so what we do is we take a powder that is actually used by the ophthalmologist, and then we use that in the coronary. And that, of course, you know, is completely off-label. We have in my hospital all those patients going through a clinical study where they are informed that we're actually using a medication that is not meant for the coronaries. And this is what we're using today. So we haven't found an alternative to acetylcholine, but this is the pathway that we use. If you want to test for spasm, an alternative would be use of metrogene. But again, I think that acetylcholine is a very important drug because it allows you to do two things. Acetylcholine has two purposes in the cath lab. One, to assess the endothelial function, which is becoming increasingly important. And second, to test for spasm. So we assess endothelial function at low doses and spasm at high doses. And this is the protocol that we use in our lab. We have done around 300 patients with this team, and it's extremely safe to use in the corner.
The other question is, in the Coroventis system that's available in US, it requires adenosine infusion for CFR IMR measurement. The other system that you were mentioning in your lecture, does that require adenosine infusion as well?
So for the epicardial part, I think you can rely on resting indexes. If you want to induce hyperemia, there are a couple of situations where, in my opinion, hyperemia should be used. We abandoned adenosine since I think 4 or 5 years. We're using nicorandil and papaverine as our hyperemic agent. And again, as adenosine becomes the last alternative. And both papaverine and nicorandil and nicardipine have sufficient hyperemic plateau to do bolus hemodilution in the hyperemia. So theoretically, you can also use that to assess.
Okay. I think that was very very insightful. And the last question is that, what do you think about all the negative FFR trials recently?
You know, that's a very important question. And the benefit of all the FFR trials, if you look at this in detail, and we can start by phase 1, which is the landmark one, is the fact that when you start to defer lesions that are not ischemic based on physiology, you immediately get a benefit of reducing the complications associated with the PCI. You can call this periproximal myocardial infarction, you can call this whatever you want to call it. So you reduce those, and the value of reducing stenting is acute, so reduction in procedural complications, and of course, reduction in the complications associated with stenting. If you look at all the negative FFR trials, none of them have been meticulously assessing periprocedural complications like we're done in FAME, like we're done in ischemia, for example. All these trials have not collected periprocedural enzymes, etc. So this is mainly the reason. It's a trial design issue in the physiology trials that have led to this apparently negative, because when you look at these drugs in general, they have less stenting and the same outcomes. So it depends on how you want to interpret the data, but again, there is a design issue in those trials that doesn't allow to capture the benefit of reducing PCI complications plus the long-term benefit of having less metal in the coronary artery.
Okay, great. I think that there are some other questions, but we will field them on the online. Thank you so much, Carlos, for such a wonderful presentation and taking the time on a Saturday afternoon to do this. I really appreciate it. We'll look forward to having you again.
Thank you, Raj. Thank you for inviting me.
Thank you. We will continue in the journey of precision PCI, and now it's my privilege and honor to have my friend from New Delhi, Dr. Balbir Singh, who is the new chairman of cardiac sciences at Max Healthcare. He keeps an incredibly busy schedule, but it's thank you very much for taking your valuable time to discuss OCT in 2024. Where do I find it most useful in clinical practice? He has an immense experience with the OCT of thousands of cases. So this will be a very insightful presentation. Balbir, the floor is yours.
Raj, thanks for inviting me to this beautiful meeting, and I congratulate you for the rising success of your journey to C2. And can I have a button for share screen, because I can't see one here?
At the very bottom, it should be in green color.
It's not there.
Hmm.
I can't see the button.
Let me see. Okay, now see if you can see it.
No, I don't. I am not able to see the share button.
Everything is okay at my end.
I have no idea what's going on. Shall I try to log in again, maybe?
You can certainly try that, but it should be
It's
it
saying
should be at the
security.
bottom of.
Okay, let me try. Allow participants to share screen.
Yeah, I have multiple participants can share simultaneously even, so lots of people can show.
Let me try to re-log in again. Let me see that if it works. I got it now.
Oh, okay, great.
Okay.
Okay, we can see them now.
Okay, so I'll just put it to the full mode. Can you see my slides?
Yeah, optimal stent expansion slide I'm seeing. Yes, yes.
Okay. Okay, so today I'm going to discuss about OCT in 2024. Starting from data to practice, what are the learnings from patients, and what are the latest imaging trials that are going to show us? So OCT has a great advantage. Till now, we always talked about good resolution. We want to see everything that is possible. And it makes sense that if you have an imaging tool which can tell you so much information, why not get it? And I can see the improvements that are happening year on year in the OCT arm. So we started with CT, we started with angiography, came to intravascular ultrasound. For decades, intravascular ultrasound had no competition, and now comes in OCT for last 1 decade. And we see that IVUS has also started improving. And now we have two good imaging tools, the IVUS and the OCT. OCT has an advantage. of giving better resolution, looking at that effects even better than what we can see with IVUS. So if we look at resolution matters, yes, it matters because we want to see the details. We want to see the 3 layers. We want to see the calcium. We want to measure the thickness of calcium. So we want every information that you can gather by these imaging tools. But what has happened is that the guidelines have not been too happy about pushing this into a class 1 indication. In 2018, you can see ultimately after a lot of trials came up, it came to a 2A platform for stent-related mechanical problems, and for left main, IVUS was 2A. So you can see the guidelines have not been so kind to these imaging tools. So we'll see why. Optimal stent expansion is one of the key parameters for a good angiographic results. We know that, and there is no doubt about it. Malopposition is another important tool. And you can see how OCT can pick up malopposition. Actually, it is so easy for an operator, even a less experienced person, can pick up these findings of malopposition, underexpansion, dissection quite easily with OCT. So the edge dissections are seen so clearly by OCT, and we know that some of them may not matter and some of them may matter a lot, and it is the clinical judgment that is required in many patients. But you have data, you have something to see on that. Plaque protrusion, thrombus are so nicely seen, and now I'll take some case examples to help you understand this. This was a prestige trial which looked at stent thrombosis and MI happening because of stent thrombosis. And they looked at multiple parameters were found, and they looked at malposition, underexpansion, thrombus, and a distal edge dissection. So in one patient, you can see A, B, C, D. A is a dissection. At the distal edge, you see a false lumen and a true lumen. B is presence of a thrombus and plaque prolapse. C is an underexpanded stent strut. D is a malopposition. In the same patient who had ended up with thrombosis, OCT picked up so many findings. So you can see if they were picked up earlier, this patient may not have had a stent thrombosis. Look at this another example, that this is a beautifully elegantly placed everolimus stent. EES is marked as the stent, so it was placed there. And few months down the line, patient comes with an edge restenosis. But if you look at this patient had a OCT at the end of the stent implant, you see at B, there's a lipid-rich plaque. The lipid is identified by low attenuation. You can see a low attenuating plaque between 2 o'clock to 6 o'clock, clearly telling you that this is not the place you want to place the stent. Then the stent is expanded and the distal part is fine.
Actually,
And
we do not see the slides, excuse me. We see a white slide zoomed in very big from the beginning. Thank you so much.
let me see now if you can see. Do you see it now?
Yeah, I
No?
see the angiogram. I think that it's resolution. Oh, okay. Now we can see the whole slide. But the resolution of on your computer, okay, now we can see.
Okay, so
But
let's see.
something is off a little.
Okay, so now you can see now.
Yeah. So can you go on a slideshow? There's that button at the bottom in the PowerPoint.
I am on the slideshow. Let me I'll try to share again. There is some problem. I don't know what is the problem, but I'll try to share again.
Okay.
Okay. Now you will be able to see.
Yep, we see perfect. Yeah, much better.
So now we go to the next slide. So let's look at a case example. This is a complex PCI, undoubtedly a complex PCI. You have LED, which is occluded. Then it fills down a big LED. You see the circumflex, a short left main, a proximal LED, you see a big OM, which has got a tight stenosis, and you have multiple stenosis. And this patient did not want a surgery. In fact, he had some contraindication, and surgical team denied a surgery, and he also didn't want. Now, doing this case, let's look at so the CTO of LED, which was first attempted, then proximal part of LED, another stent. Now we have this LED picture, OCT. Now let's look at this OCT. So this is the distal part of the stent, which looks the distal landing zone, very clear. Mid part of the stent, optimally inflated, overlap, nicely done. Now we'll go to the angiogram. So this is the angiogram. We have evaluated the mid part of the stent. We see the proximal part of the stent looks great. This is the OCT of the proximal part of the stent, which shows an MLA of 5.93 at the ostium of the LED. Now, this is not acceptable. Angiographically shows good expansion, but if I get the MLA of 5.9 at the proximal LED or the ostium, I'm not happy. A 3.5 balloon was taken back to dilate that lesion. And similar angiographic result is here. You see the top picture, same angiography, another angiography, which is same. But if you see the MLA, it is from 5.9 to 8. And in my opinion, I have no doubts that the outcomes between 5.9 and 8 are going to be remarkably different. So if you're doing such a complex PCI, it is very worthwhile to have an imaging tool which gives you information of so much that is to be seen. Let's look at an example of a stent failure. This is published in JACC. This is a patient who had a stent failure. These are the points X, Y, and Z. You see the point Y. The stent has hardly expanded. In the frame A, look at Y. It is not an expanded stent at all. And this has to re-stenose. And if you put another stent into this, you will be in a complete disaster. You wouldn't know the next stent would come back with again a 99% stenosis. And there is no way angiographically to tell that this stent has not opened at all. And all that was done was a high pressure balloon dilatation, opened these struts completely, and this patient goes home with a B, and on follow-up at 9 months, the image is C. No more stents, only the stent was expanded, which was the missing link. So to diagnose stent failure, OCT is a great tool. So we understood stent under expansion is a great predictor of stent restenosis and thrombosis, even with the best of the stents that you may use. Now, people tell me that, look, complex is fine. Why should I do OCT in simple lesions? And my answer to this has been rather different. Let's look at this diabetic lady. Now, diabetes is a different disease altogether. And when they come with ACS, then you have to think. This is a lady who comes with ACS. We see a plaque which is lipid rich, but in between there is calcium too. You see the frame, the last frame, on the right side, the artery is big, but on the bottom you see a big calcific plaque. In the second frame, which is showing a very tight stenosis, which is lipid, and there is calcium, which is deep calcium and circumscribed. So there is calcium and a lot of lipid. But anybody would say this is a simple 15-minute procedure. And true, it was a 15-minute procedure. Now, there are 3 diagrams here, A, B, and C. These are the 3 angiographic views. Look exactly same, exactly same. Frame A, the OCT shows an MLA of 3.28, and you look at this figure A, in between, you would see how badly stenosed this stent is. This was post-dilated, and then the MLA from 3.28 became 3.78. But the angiography shows it to be exactly the same. Further dilating with further high pressure balloon, you see the MLA from 3.7 is 5.04. And these are the 3 images of angiography. I can bet nobody can predict that figure A is so bad, 3.28 with an expansion of just 56%, which is really pathetic, and an innocuous looking lesion. So to me, this argument that reserve it for only something difficult can be sometimes wrong. Then we come to calcium. So calcium is a strong predictor of underexpansion. And we've seen multiple examples. And we now have a score on OCT, which uses angle, the thickness, the length to decide as to what you do to this patient. If the score is high, you're already towards thinking about devices, atherectomy, IVL, but that means you are working on it. Even if you decide not to use these devices, even if you decide that I would go with an NC balloon with high pressure, it's not a bad idea. You can do that. Check after the balloon dilatation. Have you made that space? Have you made those cracks? Will your stent expand well? Look at these examples. Look at the example C, where the thickness is 1.4, the length is 11 millimeter, the calcium score is 4 points, and the stent expansion is just 68. Tells you that how robust this criteria can be. So when you get a high score, whatever strategy you apply, but you have to work hard. You have to do everything that you have in your pocket to get this patient with a good stent expansion. And if you have that in mind, you would be, I can tell you, you would be getting a good result in 80 to 90%, not even less than that. But don't expect 100% will get a stent expansion of 80% or more, but majority will get if we work hard with these patients. Let's look at this lesion. Angiographically, mild calcium. Definitely looks mild calcium. And many people would say this case wouldn't take more than 15 minutes. And this is what happened. The balloon didn't cross, so rota was done. After the rota, look at this RCA profile, a very big artery, but the calcium, thickness, length, diameter are all around the vessel. Tells you that, look, you have to do some things better than what you. And rota did a good job, followed by NC balloon. And look at the expansion of this stent. This is what you want, this kind of expansion. You want with calcific lesions. If you get that, you will be always happy that you produce a great result. And this was the final picture. You would see that a 4 millimeter followed by a 4.5 millimeter balloon was used to finally get this kind of a result. But you are working every step. You will be doing more imaging, but you will be working every step. Bifurcation lesions, and I will discuss the October trial also subsequently, are another important areas. Now, this is a patient who has a distal left main and looks so complex. He's 87 years old, LV dysfunction, looks so complex. And how do you stent it when you are not understanding where the lesion is and how this lesion is? So OCT for left main bifurcation gives you a lot of things. This 3D bifurcation view, the knowing where the wire is, going through the struts, using your crush techniques well can help do very difficult cases quite well. So bifurcation is a great tool for OCT. Let's look at not so difficult case, but this is a 55-year-old young male with an LED lesion, and look at the diagonal. So LED is tight, diagonal is almost occluded at a very big diagonal. So we were able to cross both, dilated both, and went for a DK crush technique. After the DK crush technique, the problem was that we were not able to cross the side branch with a balloon. And if we are not able to cross the side branch after a DK crush, that means no kissing, and that means full of problems. Now, this is where you see the two wires. So we brought in the OCT to the main vessel, trying to figure out what's the problem. And the problem was very simple. You see this diagram on the top. You see one wire is in the LED, the second wire is the diagonal, and there is total crowding of struts around this diagonal, not allowing your balloon to go in. So where is the problem? You look back, the amount of stent that has been crushed behind in the LED is large, more than what we would have wished to do. So that means there is a this decay crush technique is actually more like a crush here, because there is more stent struts behind this LED. You see a lot of stent struts here, and I will point it out with a laser pointer. You see the struts all along from here to here, and you see the crowding around this diagonal of stent struts. This is the diagonal wire which goes through. And if you see the transverse section, this is the struts which have not been expanded. All we needed to do, this was 4 millimeter, and we were dilating with a 3.5 millimeter. All we needed to do was get a 4 millimeter balloon pot, go on high pressure, smoothen out this area, and the balloon just slipped in after that. And all that was needed was understanding what the problem was, and OCT, 3D OCT. And it was so easy to get the balloon after that and get a decent result on this LED diagonal. And this is after the procedure on the same patient. You see how nicely it has opened up this diagonal. And now you see the stent start have been thrown away from this diagonal. And it's very clear that this is a good result. And bifurcation has become another important area after the October trial, which is just presented at ESC. What about a long disease? This is a long LED lesion in a diabetic lady. You see a long diffuse LED lesion, symptomatic. And we did her LED, so I'm not going to show the pre ones. I'm going to show this LED to you. So this LED is an angiogram. And if I ask you how is the result angiographically, I'm sure most of you would say that it is time to pull out the wire and go. Let's see what, this is the RO caudal. So you can see two projections angiographically. Let's see what the OCT had to show. OCT had to show a big thrombus. I'll show you the big thrombus. This is the transverse view, and this is a lot of thrombus in this. You see on the transverse section, thrombus sitting here, a huge thrombus. And this thrombus, if you leave this patient and goes to the ICU, this LED has a high chance to occlude right in the night. And you don't want that. So obviously, this is not seen angiographically. So two views I showed you. Expansion seems reasonably all right, but there's a thrombus. So what do we do to this thrombus in this patient? We thought the results were good. So pharmacological therapy was done. Further high pressure balloon dilatation was done. Repeat OCT after 20 minutes. This is what it is. Thrombus has cleared up completely, and you see a well-expanded stent in this picture. And this is the angiogram after this, which looks same as what you saw just a few minutes back when the OCT catheter was inside. So this is something I showed you from clinical data, from patient experience, and these are cases which can change the outcome for the patient. But question always, I will say yes, Raj, you will say yes. The purists want to see the data. They want to see the data to change their practice. So what is the learning from the latest imaging trials? So at the ESC, a lot of imaging trials were presented, and I'm going to show you the results of some of them. As of now, this is what we are at 2A. What will it take to make it 1? At least there is a lot of things to show now. So this was the first trial that was presented, which was the Illumin 4. Ziad presented this trial at the ESC, which is a randomized trial in complex PCI to OCT guidance and angiographic guidance. Very interesting part of this trial was that after the angiographic guidance, there was one OCT run taken for all patients, and the operator was blinded to this OCT. While in the OCT arm, pre, post, and every step was taken to optimize the result. Minimal stent area was taken, and the primary endpoint was a target vessel failure at 2 years. We were one of the top 10 enrolling centers, and we know how difficult this trial was to conduct and how many, there was a core lab and every value was checked. And we had to meet a compliance of 90% in our value with the core lab. Otherwise, it could have been rejected. So the primary imaging endpoint, if you look at the minimum stent area by OCT and angio, was significantly different. You can see 5.7 versus 5.36. The difference was significant with OCT. So if you have an OCT guidance, you have a much better. Dissections, major dissections, which were missed angiographically, were 5.1%. And this also was significant compared to OCT. The primary endpoint, you can see OCT guided PCI was lower, but did not meet a statistical significance. And there are many reasons for that. Geographical differences, differences because of poor follow-up during the COVID era. So there were a lot of discussions around this. However, conclusions were that OCT results in larger minimum stent area with greater stent expansion. OCT leads to fewer dissections, fewer malappositions, less protrusion, less untreated focal segment disease, and there was reduced angiographic complication. The TVF was not different, which I suggested, but there was one very important difference. OCT reduced stent thrombosis. And this is very, very important to understand that this was statistically reduced. So there were fewer trends for fewer cardiac deaths and MI with OCT guidance. And this rates of TVR were lower than expected. So the statisticians had actually expected higher TVRs in both the groups. And it came out to be much lower. And was it COVID which was responsible, or the operators are getting better, which is leading to this lower TVR is yet to be understood. But it's a very encouraging trial, contrary to what many think. The other trial was OCT in complex bifurcation, which was the October trial. This is a European trial. So it had an OCT arm and an angiographic arm. So the characteristics you can see very similar on both arms. And you can see that there was, in the element 4, the left main was not included, but in this bifurcation of left main was included in the October trial. And you can see majority of had an LED diagonal bifurcation. And you can compare these two groups are practically similar. So what was the endpoint? Was the MACE, the cumulative MACE. You can see there was a huge difference, and the hazard ratio of 0.70 with a p-value of 0.3 with a 2-year follow-up, resulting in OCT arm being better than the angiographic arm. And all subsets, whether it was left main LED, whether it was one stent technique or 2 stent technique, OCT arm did better than the angiographic arm. So conclusions from the October trial were that bifurcation, complex bifurcation, where complex bifurcation was defined where the side branch was more than 2.5 or the length of the osteal lesion was more than 10 millimeter, was defined as the complex bifurcation. And many had 2 stents, but some had 1 stent also. But conclusion was that imaging with OCT, and in this trial, I showed you how wiring is to be checked. Each step, there were at least 5 or 6 steps of OCT to be done. The wire position had to be checked. The crossing with the balloon had to be checked, and the protocol had to be followed. So if one wants to replicate good results of OCT in bifurcation, one must read the protocol of this October trial because it's very meticulously done. Then there was a Korean trial, which was IVUS, which compared IVUS versus OCT. And this was all comers, 2,000 patients in routine clinical practice, randomized between IVUS or OCT. And the primary endpoint was cardiac death, TVR, myocardial infarction, or ischemia-driven revascularization. And you can see practically the same OCT arm, little better than the IVUS, but the p-value for non-inferiority was less than 0.001. So telling you that practically similar results could be obtained with two good imaging techniques. So in conclusion of the Octopus trial, patients undergoing PCI for diverse coronary OCT guided was non-inferior to IVUS guided PTCA in terms of the primary endpoint. However, this was a all-comers trial, and again, they reported lower than expected event rate, which was very similar to Element 4. So summary of this was put by Greg Stone, and he said that now we have 22 randomized trials, more than 15,000 patients. IVUS has 15 randomized arms. OCT has 11, one randomized trial of OCT versus IVUS. 19 trials have angiography as the arm of randomization. So we have so much data. And he tried to put it into a meta-analysis and try to understand with OCT versus angio, OCT versus IVUS, and try to make some conclusions out of this, which are very relevant conclusions. And 19 trials, 13,000 patients. What were the immediate conclusions? First conclusion, I will intravascular imaging, OCT or IVUS versus angiogram. 19 trials. You see the Netwick estimate that it favors imaging over angiography. Clearly, no doubts. IVUS versus angiography favors IVUS for so many randomized trials and a large number of patients. OCT versus angiography favors OCT. Less number of patients, less trials, because OCT has been more recent. OCT versus IVUS, practically same. Few trials, but whatever data is practically same. Octopus, Element 3, Mustic are probably bigger trials, but Octopus was the biggest trial, so the data pulled in suggested that. So network meta-analysis suggests something very important, that you could reduce cardiac death, you could reduce MI, you could reduce TLR, you could reduce stent thrombosis, you could reduce all-cause death, you could reduce MI. And this is a big thing. This is not a small thing, that if you can do that, I think it is time for us to now rethink of imaging as an important tool in our clinical practice. And the routine use of OCT or IVUS to guide PCI procedures will reduce mortality, improve patient care, and it will shift the guidelines into thinking differently very soon. Which type of lesions which benefit with more with IVUS or OCT will be determined by a physician practice. In my practice, calcium would take OCT, bifurcation will take OCT, LM bifurcation will take OCT, osteal lesions will take IVUS, and if patient has higher creatinine, it will be IVUS. So it is not that one will replace the other one. It was the choice which will differ with the patient selection and the physician choice. So with this, I end my talk, and I hope I have been able to convey what was entrusted to be conveyed. Thank you very much.
Thank you very much, Balbir. It was a very comprehensive, excellent presentation with all the latest information on OCT. I'm only going to address one question from the audience for this, given in the interest of time. In your clinical practice, you have obviously access to both IVUS and the OCT. How many percentage of patients gets an IVUS versus the OCT?
So in my practice, it is 70% get OCT and 30% get IVUS. But it could differ from lab to lab, clearly different.
Sure. The calcific, this is one more item that's out there that's we should address. This is in calcification. Does OCT change your approach in terms of the selection of the device?
Right. So OCT gives me a thickness and a delineation of the calcified nodule, which IVUS cannot give. This gives me an advantage of determining what device. But nobody has done a study comparing IVUS or OCT, especially for calcium. So again, it will be personal choice. But IVUS cannot tell you the thickness of calcium.
Great. Well, thank you very much. Outstanding presentation. We look forward to having you again in future. That was a fantastic overview. Thanks so much, Balbir, for taking valuable time from your very busy schedule. I know it's crazy out there and how busy you are now. But thanks again. We'll continue this session. And now it's an honor to have Dr. George Vetrovec, who does journal notes with our every C3 live show. And here he is back again with another edition of journal notes and some interesting articles and discussion. Dr. Vetrovec.
Thank you very much, Raj. It's a real pleasure. I've got a few things today to cover from the journal side. The first one is, I just wanted to make the note that Val Fuster is stepping down as editor of the Journal of American College of Cardiology, JACC, and he'll be followed by Harold Krumholz, Harlan Krumholz, who has a long history of involvement with outcomes and interaction with Medicare and so forth. His statement is here: the opportunities ahead for JACC to be the force of good for our patients, our profession, and society, said Krumholz. JACC has the potential to shape the future of cardiology. I'm eager to engage with worldwide to build JACC's successes. It'll be interesting to see. I think it will have perhaps a little bit different flavor than we've had, certainly focusing on outcomes and cost and so forth. So time going ahead would be interesting. He's had huge Medicare experience. So in terms of actual publications, I wanted to first talk about a publication which was just in JACC, and this is the health status after transcatheter tricuspid valve repair in patients with severe tricuspid regurgitation. And the background is that the Triluminate pivotal trial looking at edge-to-edge T-tier treatment of TR versus medical treatment showed that you could reduce mitral regurgitation, but it didn't meet clear, just simple improvements in outcome in terms of survival and heart failure. So this was a sub-study of that to try to understand the significance of health status improvements that were demonstrated in the Triluminate trial and to see how that perhaps predicted. So there were 175 patients in the T-tier group and 175 patients in the medical group. They were evaluated with the Kansas City Cardiomyopathy Questionnaire over the course of the study. And the only patients eliminated were a very small percentage that didn't comply with this. And the results are simply that the improvement in health status was substantial and early for the tricuspid valve repair patients. And there persisted a little bit of further improvement by 1 year, but that was not major. But it was a huge difference compared to the medically treated patients. And if you then look at the outcomes, you see here this increase in the blue line, which is the tricuspid patients that were repaired, and you see it persist 6 months. It's a little bit better over at 1 year, maybe a little bit better, but it's very flat. There's some improvement in the medical patients early, but it's a very significant difference. So the question then becomes, where does this fit in terms of what happens? Well, when they did an analysis of the patients who had a significant improvement in the first month, they tended to persist, and they were the ones that showed an improvement in a reduction in relative risk of death, heart failure, hospitalization, or death or heart failure hospitalization. suggesting that the patients with the big benefits clinically or in terms of lifestyle were the ones that had the physiologic clinical benefits. Obviously, a lot of questions about this, but it is encouraging. So their conclusions are that the T-tier with the TriClip system resulted in substantial and sustained health status improvement in patients with severe TR compared with medical therapy alone. They did not push the concept that they had totally changed the course of this disease. The editorial was written by Wayne Batchelor and two other colleagues, emphasized the potential benefits of, obviously, quality of life for physicians. We want people better. Did note that there were biases because there was really no blinding whatsoever in this study, and still suggest that we need more definitive data and longer-term follow-up to assure that the improvements seen in this patient population were truly related to the reduction in tricuspid regurgitation. I personally think this is kind of an exciting trial. We can quibble about some of the results, but I think it's very positive. And those of us who've seen patients with bad TR know how disabling this is. So I'm encouraged by this. Any discussion, Raj?
Yeah, so George, one issue that I was thinking about when I thought about TR repair is that we would need a newer technology, for tricuspid valve, because it's very horizontal. The current aortic valves, especially Medtronic and Edwards, they're stiff cages, and even when the aortic valve is very horizontal, it's sometimes hard to line those valves up. So of course, if we do a transapical approach and we go with an open chest thoracotomy, it will be fine. But if we plan on doing this from the groin, which I suspect that's how the technology is going to eventually proliferate, we certainly think that there needs to be a newer type of valve. Dimitri is joined us now. Dimitri, what do you think about the tricuspid valve technology?
Hello to everybody. I'm sorry I jumped in the very late moment. I'm sorry, we had an emergent case here in my hospital. I think all the studies demonstrate that the edge-to-edge repair of the tricuspid valve, even though it doesn't make any significant difference in terms of death or rehospitalization, but it seems that it improves the quality of life significantly. And this is very important because at least all what we see in our hospitals lately are patients with severe tricuspid regurgitation. We cannot do them nothing. I mean, we just give them some drugs. They have all those patients coming in every second week, every second month, probably, and we cannot offer them any important treatment. I think even this quality of life is very important for those patients. And I do believe that we as a cardiology community, as a scientific community, we need to pursue more in finding solutions and treatments for tricuspid regurgitation. I think it's an important chapter in cardiology, which we haven't yet given any significant solution. I think at least this is my point of view to this important matter.
So certainly a very important topic, George, and I think that we'll look forward to seeing newer technology and newer ideas and more studies for tricuspid.
Yeah, I think so. I think this is it's a start. Got to start somewhere. Let's move on to which I thought was an interesting focus, which was on peripheral vascular disease. This was published in the last 2 weeks in the New England Journal of Medicine, drug-eluting resorbable scaffold versus angioplasty for infrapopliteal artery disease. I think everyone is aware that angioplasty doesn't do a very good job with all kinds of things that have been tried over the years with high failure rates, partly because of progressive disease or inadequate initial results or recurrent restenosis. And the impact of so-called drug-eluting but resorbable scaffolds is really not well known, at least prior to this study. This is a multi-center trial which randomized 261 patients with chronic limb threatened ischemia, infrapopliteal vascular disease in a 2-to-1 fashion, favoring revascularization, and they used an everolimus eluting resorbable scaffold or angioplasty, standard angioplasty. And the primary efficacy endpoint was freedom from 1, amputation above the ankle of the target limb, occlusion of the target vessel, or clinically driven revascularization of the target lesion. And 4, the fourth category was binary restenosis of the target lesion at 1 year. The other was, and it was a safety endpoint, which was freedom from major adverse limb events at 6 months and from perioperative death. So recognize that the success of the study was kind of a negative result. That is the freedom from these 4 things that I've listed here. So in terms of the results, there was no primary efficacy endpoint, which is good. None of those 4 things happened in 135 of 173 patients in the scaffold group. And no events occurred in only 48 of the 88 patients in the angioplasty group. This is 74% versus 44% with an absolute difference of 30 percentage points. And its one-sided t-test is statistically significant for superiority. In terms of the primary safety endpoint, this was observed. Again, it's a high number is good. In 165 of 170 patients in the scaffold group, and in the angioplasty group, it was 90 of 90. The statistics on it was not non-inferior. So overall, safety stable and effective in terms of less adverse events. This looks at the Kaplan-Meier curve for this. The scaffold patients are in the sort of orange color here at the top. The angioplasty patients here are blue, and you can see how they fall off over the days of follow-up, and the scaffold patients do significantly better. So the conclusion is that among patients with chronic limb threatened ischemia, infrapopliteal artery disease, the use of an everolimus eluting resorbable scaffold was superior to angioplasty with respect to this primary efficacy endpoint. The study was funded by Abbott. This looks at this relates here the clinical trials government status. Now, an important point is it's why. And the theory is that the resorbable scaffold provides stability of the lesion for any dissections and so forth acutely early on. It provides a vehicle for drug delivery to reduce restenosis, but then it resorbs, and the resorption may have an advantage in that it allows the artery to remodel in a more favorable fashion, which may be the reason that it has this overall benefit. So the editorial for this was written by Joshua Beckman, and he made the point that this demonstrated patency plus a clinical benefit. And he made the point that in a lot of these peripheral vascular studies, they're now starting to what he determined as maturing to include dual endpoints, not just an open artery, but how did the patient do? And he congratulated the authors on including this in this. And he made the points I just did about the reasons for the advantage of allowing more favorable vascular remodeling. So Raj, any discussion?
Yeah, so this is very, very important. Critical limb ischemia obviously is a huge problem. You know, we do a lot of vascular work, so we know that these patients frequently require revascularization, you know, angioplasty below the knee, especially in diabetic patients with small arteries, are very short-lived. You know, they have to be redone generally within 3 to 6 months to get the wound to heal. So the other important thing about this particular study is that they absorb a stent which was utilized in this particular trial is not the platform that was utilized in the coronary. This is a thinner stent. It's a longer stent, and if the cost, you know, is not prohibitive, then it certainly can be a game changer, because over time, you know, these arteries can remodel, and supposedly the stent will completely dissolve, and it can keep the potential target available for future bypass. The important to note, however, that Boston Scientific also sponsored a study 2 years ago, and they used also a everolimus eluting self-expanding stents below the knee, and that trial did not succeed. So it's good to see that there is another drug eluting study now. This is actually the first drug eluting study below the knee that's positive, because all the drug-eluting balloon trials, at least in the US, so far have been negative, and so has the self-expanding stent. So I think this story is not fully written yet. In my opinion, this stent will undergo further investigation. I think that we are going to develop new protocols for these patients in terms of what dual antiplatelet therapy should they have, how this stent should be implanted, and whether imaging would have to be utilized for below knee arteries to do absorb stent implantation. So there is a whole host of issues that's going to come along, you know, with this technology. But it's a, you know, extremely important area, and in comparison to, you know, today's coronary market, you know, this is a huge market, because there's so many arteries in each patient that needs to be revascularized, but it will require some effort to get this technology to mature to an acceptable level.
You know, Raj, it seems to me that an important issue in this is probably going to be vessel size, because, you know, in the coronary, although it was a thicker stent, the patients who had less than 2.5 vessels or 2.5 vessels did very, very poorly. And I was on the FDA panel that made recommendations about it, and the recommendation was it not be utilized for small vessels, basically, because it didn't work well. And so I think in the periphery, hopefully you'll have better sizes, better vessel size that will help this too.
Yeah, there definitely is patients, especially in the proximal and mid segment below the knee, you know, should generally be 3 or greater. And if you go very distally, then it gets a little bit smaller. But, you know, with orbital atherectomy and a laser type devices, we are able to dilate majority of these arteries up to 2.5, you know, even at the ankle level, to try to do some durable outcome. But I think it's a great study. In fact, you know, our February show, the entire show is dedicated to endovascular. There has been an immense amount of controversy regarding atherectomy. There has been a large amount of publication at ProPublica, which is a public site, criticizing endovascular procedures and atherectomy procedures. And there has been New York Times articles about this. So it's a really, really hot issue. in US now about what's going to happen with endovascular intervention. Clearly, there are different interest groups out there, that, is trying to control, the destiny of this unfortunate patients. But I think that, tune in for February session for, further insight into endovascular therapy in critical limb ischemia and claudicants.
If I
All
may
right.
make,
Yeah, go ahead,
So-
Dimitri.
yeah, I think it's really important to have more data regarding the technical details of those procedures and the anatomical details of the patients, because at least our practice, when we have those patients with these threatened limbs, I think we have really a problem. We can see indeed patients with diffuse disease. I cannot imagine even where to put a stent in those patients. We have to stent the whole artery. I mean, we are talking about 100, 120 millimeters of stents. So are those stents are coming so long? I mean, because for our short experience with coronary by observable stents, we needed to prepare the lesion well, to have really good expansion of the vessel. Can we really do this in these really bad vessels below the knee?
Not routinely, I don't think. I think that you're going to have to look for focal disease. You're going to have to look for dissections and suboptimal angioplasty results, because most of the time we are using long balloons, like you said. There are, occasional cases where you may find a lesion that's a little shorter, but I almost think that, if you really want to stent a fair enough portion of the vessel, you're going to have to at least stent about 150 to 160 millimeters to get really a proper stenting, in below knee artery.
Correct.
George?
All right. One more quick one, and I'm going to go actually to the main image from the study. This is a sort of an op-ed piece. This is Cardiovascular Medicine and Society, written by a group of nurse practitioners and PAs. And this relates to, and the American College of Cardiology clearly has supported the role of the advanced practice providers. They have a whole section on cardiovascular professionals, which include such individuals. So this is kind of what is the role of this group of practitioners in the management of patients who are in the ICU. And so they make the point that these individuals are specifically trained, if they're going to work in an ICU and as an acute care nurse practitioner, if they're a nurse practitioner, and they're recertified every 5 years. The ACC has participated in that recertification. Physician assistants are educated in biomedical models as general practitioners, including inpatient medicine, surgery, and emergency medicine. And they are certified and have recertification every 10 years. And this diagram here just says, what is the role of this? We're being told and practicing more of these joint practice models with a variety of practitioners making patient decisions and so forth. So what is the role of the advanced practice provider? They provide clinical care. They can be educators. They can be consultants in various situations in like transplant teams. They can support various hospital activities such as Code Blue, shock teams. They can be unit directors. They can support research, and many programs are now using these individuals for that. And so they really do have a variety of potential roles. And it just sort of goes through the recognition of this. And we all know there have been some studies that have shown the APPs make cut costs, do better jobs, are better liked by patients. And we've found some that were questionable. So I think the role is just an expanding role, which is important to place in the proper perspective in the individual circumstance where it makes a difference, where it can change the outcome. And these just sort of summarize those. Conclusions here are basically what I've just said. It can be a very stabilizing force in terms of management, particularly when everybody's overworked and under stress. This is a way to distribute that among individuals who are well-trained and experienced. And many of these have been other floor nurses and so forth. So I'll stop at this point because I know we're short on time. Raj?
So George, it's important that I'm glad you brought this up. There is an editorial in the latest JACT from the current president as well as the previous president of ACC about workforce in cardiology. And I can tell you, at least in our practice, where we utilize APPs heavily, we could not do without them. So I do procedures 3 days a week, Mondays, Tuesdays, and Thursdays. And then I only get to see office patients on Wednesdays and Fridays. And on Wednesdays and Fridays, each day I see about 40 people. So I can see 80. But on the other 3 days in our practice, APPs run our office hours, and average sees anywhere from 20 to 25 patients each day. And if they were not there, it would become impossible to be able to handle the workload for our practice. They also do our HMPs for our procedures. If something else that needs to be done, discharge summaries, etc., they do them. And they see a lot of these patients in a follow-up. So I strongly encourage the use of them. I was one of the first people to hire a physician assistant 22 years ago in our private practice. There was the first, at least in central Pennsylvania, first PA ever hired in cardiology. And since then, now, each hospitals have 15 to 30 PAs and nurse practitioner cardiology teams since I started in my area here. So I think it's an important discussion, because with the shortage of doctors, senior physicians retiring, and having COVID as a problem for getting a good trainees out there, it's a more and more demand from practitioners like myself who can do procedures, at least in intervention, and we gotta have the APPs to be able to help us with the office hours. Otherwise, it's not possible.
Right. I agree, Raj. And I think one thing we didn't mention is that, they can be very supportive in terms of helping with house staff in educational roles, because they alleviate a lot of the work that the house staff were considered scut work and really wasn't educational. And we used them very early on, as you did, for all the same reason, for that particular reason, and they made it work for us. So I agree.
Well, thank you very much, George, for those very insightful. Those are great picks today for journal. Any final comments from anyone else?
I was very happy to be here with you once again. Thank you very much.
Thank you very much. Thanks so much, Dimitri. Have a great afternoon in Greece. And thanks everyone for joining from across the world. We have a huge attendance today. Lots of people from different parts of the globe. You all, people who are from Far East, have a great evening and a night in US. Everyone have a great weekend, and we look forward to having you again on February 17th. Somebody just asked me when the next show was. It's February 17th, the third Saturday in the month. The next show is going to be about, as I mentioned, endovascular procedures, atherectomy, and peripheral intervention, and some of the controversies that surround this area in United States right now. So it's going to be a very, very exciting show for 17th of February. We look forward to having you there. Thanks so much, and have a great weekend.
Have a great day. Bye-bye.